health with technology, virtual care. Yes, AI support in health, telemedicine, health with technology, technology health, automated healthcare, um, technology online consultation, application to access technology use in health. And so we can see that technology seems to be one of the key words that is dominant in these responses that we are getting. So technology, there's also online there, but technology seems to be in almost every response that we've received so far. So we'll go on to the next question, and which says, still on the same platform, you immediately see this question that will show up on your screen whilst you're on it. And it says, which of the following are examples of digital health intervention? So you select all that applies and just click. And then once you're done selecting, you submit, and then that should be it. So let's get some few responses on this question as well. And then rapidly go through the rest of the questions and then go on to the presentation. Right, we have 18 responses. It's 18, 22, have 23. For those who are still not able to access it, just scan the QR codes and that should take you to the site. You'll immediately be able to follow along with the questions, or you can type menti.com on your browser, and then type in these numbers there, 55411390. That should give you the response. That should give you the screen that has the questions for you to also give your response. Right, so as we can see here, the distribution, everybody seems to agree that telepsychiatry or telemedicine is a digital health intervention. There is varied responses for the others, but largely most people have agreed that, or almost everyone who has responded has agreed that telepsychiatry or telemedicine is a digital health intervention. It's an example of a digital health intervention. All right, so we'll move on to the next question. Have you ever used any digital technology in your clinical practice or patient interactions? And so this, yes, no, yes, occasionally or frequently, and that's yes. Okay, majority of people have used some form of a digital technology in their clinical practice, but it is occasionally. Okay, about 50% of people have used it occasionally. Yeah, and there are people who haven't used it, but they are interested. About 25% of people are in that category. Okay. All right, that's good. I think we have quite a number of responses for that as well. Let's go on to the last but one question, which says, would you feel comfortable recommending or prescribing a digital mental health tool to a patient? Okay. I'm seeing a lot of people are clustering around, maybe depending on evidence and regulation. All right. And I'm sensing a lot of people are also in the category that says yes. And so we are seeing largely the distribution between yes and then maybe depending on the evidence and regulation, which is where majority of the people who have responded um, are in. All right. That is also a good response. A number of people have responded to that. So we'll go on to the last question and then we would jump back into the presentation. We'll come back to revisit some of these questions after the end of the presentation just to determine if there have been any changes in our responses. And so the last question is, what do you think is the biggest challenge to implementing digital mental health solutions in Ghana? So this is a single best answer. So you select it and you submit. Okay. Interesting responses. We are getting a majority of people saying low digital literacy as one of the biggest challenge, and that is followed by data privacy and confidentiality concerns, cost of device and data issues as well. Okay. All right. I think we also have got quite a number of responses um, to this question as well. So that is it for the survey. As I mentioned, thank you so much for participating. We'll revisit some of these questions at the end of the presentation. So I would like to jump back into the presentation and then we'll revisit some of these questions at the end. Right. So why this topic at this time? And as Dr. Atta mentioned in his during the introduction, there is a rising use of technology in healthcare, and and mental health is not an exception. And in fact, it is one of the areas that digital technology has been used, in the past. And some of the areas, some of the digital technologies that we have actually been pioneered in mental health. And so there is a current trend, but beyond that, beyond the current trend and beyond the buzzwords, we know that there's a rising demand or there's a rising burden on mental health conditions globally and also locally within our setting where we are here. And the COVID pandemic had just only come to exacerbate that and led to a significant deterioration in the mental well-being of the general population globally. And WHO estimates that about 13% of the population in Ghana here suffers some form of a mental disorder. 3% of them have some form of a severe mental disorder. And coupled with that, you now have this paradox where you have high demand and yet the supply is not does not match to that demand. And so you look at the workforce per 100,000, we only have 10.3 mental health workers or professionals per 100,000 population in the country. And so you expect that there should be a relationship where you have, and when there's an increase in demand for a particular service, that there is an increase in demand of that supply. But that's not what actually happens because of the several factors that come into play in these demand and supply chain. And so people have sought to use various solutions, and one of which is technology, which is typically described as the most scalable resource that you can ever deploy or use. And so these are some of the things and some of the factors or reasons why this discussion that we are having today is relevant and it's important that we have or we start these conversations in as we move towards bridging the gap of demand for both access to general access and also the increasing quality of care and also our ability to provide that. So what is digital mental health? So digital mental health, when we say digital mental health, it is a use of information and communication technology. So ICT technology that is used in health, mental health services. It is boosted through internet or other related technologies such as smartphones and wearable technologies, or even immersive technologies like VRs and AR technologies. So these are all buzzwords that you'll be hearing, and a lot of us have heard them now because they have come to, they've become more popular now and are being used, by consumers. And so that is what it means when we say digital mental health. You can take that a step further and define it as the use of digital technologies to support mental health promotion. So the key words here are promotion, diagnosis, and treatment. So the use of digital technologies in mental health promotion or diagnosis or treatment. And so with this, you now have whole arrays of technologies which fall within different categories, such as telepsychiatry, mobile applications, AI tools, electronic health record system that we use in our daily clinical work, online therapy platforms, and patient education websites, and all of that. And some of them we already have identified in the earlier survey that we did even before the presentation. So that is generally what we mean when we say digital mental health. Now, the word digital health itself is a broader term that captures all of this. Now, when you narrow it down to the use of that in mental health service delivery, then you call it digital mental health. You can have it being used in cardiology, in radiology, and so you have the same technology but being adopted for the use of or for the delivery of different service because of the nuances there are in each of these different specialties or different areas. But the underlying technology is the same. So digital health is the bigger term there, and then you can now narrow it down and or refocus it into mental health and call it digital mental health. So telepsychiatry is a sub term or it's a sub technology under digital mental health. Just like telemedicine is a much broader term, and telepsychiatry is under telemedicine. And so these are just phrases which the meaning are kind of a bit self-explanatory. So how do we classify digital mental health, or what are the various types of digital mental health that we have available to us as providers that we can give to patients or give to our clients? And what are some of the ones that are available for clients to even access without going through us? And so we can classify these tools based on the definition that we just gave, the very second definition of digital mental health, which highlighted the three areas, which is health promotion, diagnosis, and treatment. So you can classify digital mental health tools under under these three categories. You can also classify them under who the end user is, who is going to be using. So in this case, you can have tools that patients will typically use or patients will typically use. And so under these tools, you can now have health promotion tools. You can have standard treatment tools, and typically, diagnosis tool we tend to leave to the clinicians or the clinical or the health providers themselves. But largely, the patients who use mostly tools that fall within health promotion and the treatment part. And so some of these ones include websites, blog posts, YouTube channels, podcasts. Let me be quick to add that YouTube here is not the technology. YouTube is not what is being described as a digital mental health tool. It is the use of it. So these are just tools. So you can use Zoom for teleconsultation, and that becomes a telepsychiatry platform. But Zoom as an application is not a telepsychiatry platform. We don't classify it as a digital mental health tool. It is a use of that. So that's why the definition says the use of. So YouTube is not a digital mental health tool, but the use of it in the delivery of mental health is what is described as a mental health tool. And so we can use that to educate patients. We can create content and have them on YouTube channels. We can create podcasts and then host experts to discuss things that are educative to patients. We have websites that we write content and blog posts that we post various blogs, educative content on that patient can access. So it is a use of the technology in delivering of the mental health. That or mental health services, that is what is described as a mental health tool. And so we have mobile apps as well. So we have apps that patients or clients can download on their phones to track their mood or for mindfulness. And then we have wearables like your Apple Watch that you have or your Samsung Watch, whichever smartwatch that you use, Fitbits, any of those wearables, any of those smart devices that you wear on, they are non-invasive and yet they collect some baseline physiological data from you, can actually also be used in mental health services. And so these largely fall within the patient tools. And then we have those that you can also classify as the clinical tools. And so those are the ones I mentioned. So telepsychiatry or telemedicine platform, in our case, telepsychiatry or e-counseling or teletherapy platform or telemental health platforms or platforms that are used for teleconsultations in mental health service delivery would fall under this. And here too as well, even though the person or the end user here would definitely be a combination of both the provider and the client patient, but it is usually initiated by the provider. And so that's why it falls within here. And it can be used for both health promotion, diagnosis, and treatment as well. And so you have digital CBT platforms, so cognitive behavioral platforms, therapy platforms that can be used by both the provider and the patient, but largely always initiated or largely mostly initiated by the provider. And then we have electronic health record systems that we use in our daily clinical workflows. So those are largely also used by providers and health systems. We have data analytics platform, which in this case can also fall in even the patient tools as well. So these are not clear-cut, classifications. It is just a way of trying to put some context in how you can go about understanding these tools. But these tools can be used and modified to be used for different participants or different user group, depending on how it is being used. Right. So big data here can fall for both health systems. It can fall for under policy. It can be used by also the patients as well. So you can have a patient facing end of the tool that collects the data from the patient and actually provides them with the analytics as well, whilst feeding it back into some clinical tool that their provider can also access. So these classifications are not by all means strict, and so there's that flow over in both sides. This table kind of summarizes most of the things I've spoken about, and so you have at the extreme end the digital interventions moving towards artificial intelligence tools, and so you have psychoeducation tools, so apps that can be used for psychoeducation, mood tracking, mindfulness. I've already mentioned these ones. Then you go on gradually to virtual reality and technology. So these are immersive technology that creates the experience of being in another form of reality. And these technologies have the ability to actually evoke similar emotional and physiological responses that you will get even when you are in the real world. And so they are typically very good in exposure therapy, specifically when you are trying to treat conditions such as the anxiety disorders, specific phobias that exposure therapy is where exposure therapy is typically used. And so these are very popular technologies that are used there. And again, virtual reality glasses are glasses that are used by consumers to play video games and to do all sorts of things. But then again, you can use them and now reprogram them to be used for this. And so it's not the virtual reality glasses themselves that are digital technology, but they are used in doing that. is what is being classified here as the digital mental health intervention. And so you go on and you go, as you move towards the right end there, you have natural language processing technology. So that's where we have these chatbots. And so ChatGPT and all the chatbots that are out there that we are all, majority of us are familiar with now, fall within this category. And smart speakers, which people can speak to, have conversation with, all fall within that as well. Then you have data science. These are machine learning models that are able to extract data, large quantities of data from either the patient uh, data or electronic health record system at the population level, and is able to make specific recommendations as to what would be the best treatment model or what would be the best regimen to give to a patient. So these are some of these models that come in there. So we'll talk more about some of these, hopefully in subsequent conversations where we go on to talk about these topics in details. Right, so this table kind of summarizes that. So just like we have, pharmacopoeias and compendiums that are used as reference in our prescription of pharmaceuticals, there is also the need for a repository, if you like, of tools that can be verified and be used by clinicians or providers in their care, and even the end user themselves who is sitting in the house and want to be able to know what tool should I use, and what is the evidence for this tool, and how do I use it, how do they use my data, and all of these information. And so there is a similar thing. And so there is that. And there is also the fact that manufacturers, people who develop these applications, and the people who use them sit in silos. There is a developer sitting somewhere building a digital health application who has no clue what goes into the care of a patient with a particular condition. And yet they can write code and develop these applications. And the person who would need to prescribe this tool is sitting in the clinic wondering how he could solve, or he or she could solve, a particular problem with a digital technology. And so we need, there's that movement where we want to bring these two bodies together, where the clinician who has the clinical knowledge and the developer that has the technical knowledge come together to be able to produce something that is both useful to the end user. There is also the rapidly evolving landscape of digital technologies in general. You would wake up tomorrow and you will see 5 technologies or 5 apps that have been deployed to the App Store or to Google Play Store that are targeting just sleep disorders. And then by the end of the week, there are already 20 of those apps. And so now you are questioning and asking yourself, out of these 20 apps, which one is the best? How do I choose, and which one do I recommend to my patient? So that rapidly evolving landscape, and also the limited evidence base for these tools, makes it necessary for them to have for us to have a unified platform or a unified place where we can have these things assessed by an independent assessor or independent body, and so that people like us, providers in our hospitals and wherever we provide care, we are able to continue to do what we do best, which is providing care, but then we are also being guided by evidence when we want to prescribe these digital tools. And so we have 2 main repositories that I recommend for us. These are the 2 main ones that are actually globally popular that you use as reference for some of these digital health tools. And so we have, so you can call it digital health formulary, just like we have DNF for pharmaceuticals, or USP in the US, or CSPS in the Canada. And so mine is mobile health, or mHealth Index and Navigation Database. And so this is popularly used and popularly available in the US, and it has a repository of mobile applications that have been vetted, through series of questions and through series of assessment before they are listed on that platform. So when you go there, you will see a whole bunch of apps that you can filter by condition that you want and by the evidence base that is there, or by their responses to the questions that they are vetted on, and whether you want a free version or not. You can filter by all of these, and you can actually go and dig deep into each of these apps to see which one is best recommended for your patients. And then we have OCHA, which is the Organization for the Review of Health and Care Apps. This is popular in the UK, and it has over 2,400 applications. And so for this, unlike mine, so mine mainly has applications that are mainly focused on the digital mental health space. OCHA has a wide variety of applications, and so their app library, scrutinize and vet apps to meet strict safety and privacy and quality standards. And so when you go there as a clinician, you are able to know that these applications that are here have been vetted and sort of, you would say, approved. And you can also read further on the evidence base for these applications. In the UK, they actually have this integrated into the NHS electronic health record system. And so as a provider seeing a patient, you can actually, just like you can list and check for medication on your electronic health record system, you can equally go to OCHA while also on your electronic health record system and search for any digital health app and recommend it to a patient. This is not a strict prescription, but it's a recommendation that you send. Patient receives an SMS or an email with a link. They go on to download this app, and you are actually notified when the patient has downloaded the app. And based on the data sharing policy, you are able to actually see some activity depending on what the functionality of the app is and all of that. So these are some of the two main repositories that you can kind of use as a reference material to search for some of these tools that we've talked about, if you are looking to recommend them for your patients. Mine, for instance, goes through series of rigorous assessment, as I mentioned, and these are some of the 5 pillars that it is assessed on, and this is based on the American Psychiatry Association's app evaluation model. And so they have these 5 pillars on which the application, before the app is listed on Mine, has to be assessed on, and these 5 pillars have been expanded to over 105 objective questions. And so before an application is actually listed on this platform, you have to answer these 105 questions, and those questions are grouped under these 5 pillars. So when you go and you search on the database, you are able to see what the response for each of the app is and how they perform under each of these pillars. And so you can, at every point in time, see which of the pillars you want to prioritize for this your patient, because an app might perform very well on the therapeutic goal that it says it's going to do, but not so well on engagement or not so well on accessibility, because it is probably the paid feature and not free. And so it means that not everybody will be able to access that. And so under accessibility, you will see questions like, who is the app developer? How much does it cost? Does it work offline? And is it accessible with all the features, even when it's offline? And the questions of privacy and security issues, there will be questions that ask whether the app uploads the user data to anywhere, and what are their privacy policy, and what security measures do they have in place. These are some questions that the app developer who is uploading their application to the platform will have to answer in order for their app to be listed on. Under clinical foundation, which is the other pillar, it will be asking questions whether this app is actually evidence-based. So is there any evidence backing this application? Have you conducted any study at all to back the claims that you are making about this application? And is it able to does it accomplish what it claims to do even when it's offline? So these are some questions that application developers are typically made to answer. And as I mentioned, it's an array of questions, over 105 questions targeting these 5 pillars that they go through in order to have their applications listed on Mine. So if you go to Mine, you'll be able to filter by these and know what kind of application you are able to recommend or prescribe to your patient, depending on what you are trying to accomplish. So what are the benefits of digital innovations or the use of digital innovations in mental health? The obvious one is access. It can reach places that are very hard to reach. Populations that are underserved are able to have access remotely without the logistics that will usually be involved in a face-to-face or an in-person care delivery. And there's a bit of scalability as well. As I mentioned, technology is mostly described as one of the most scalable resources in anything, not just only in mental health. And you can use technology to augment the workforce deficiency or deficit that we have. That is not just only peculiar to Ghana or to low and middle income countries. It's a global deficit, and we can use technology to do that. And that is one of the benefits of using digital innovation in mental health care. There is convenience. Patients can conveniently schedule an appointment based on when they are available and when the provider is available, and they can have these at any time, anywhere. Uh, and there's also the anonymity as well. And so mental health is notoriously is it has this stigma that is associated with it, and so people tend to shy away from even going to physical buildings that are categorically labeled or categorically described for mental health care. And so we can use this as a digital switch or a digital bridge where people who are seeking mental health care for the very first time will be comfortable sitting in their house having a consultation with somebody who nobody knows their specialty or the care that they are giving to them. They will be comfortable doing that. And just that anonymity gives them that comfort. And then as they go on and gradually progress through their therapy sessions or their counseling sessions or their consultation sessions, they become comfortable, and then they might actually get to see that it is not as hundious as they think or as they had actually thought, and that this is actually medicine, and this is medicine just like any other medicine or any other physical health condition that they would go to. And then they become more comfortable, and they would consider going in for face-to-face or in-person consultation as well. So in some countries, that's actually one of the bridge, especially with the current generation where a lot of they are born into technology, and what they know, most of the things that they have done so far has been virtual and has been remote. And so they are more comfortable using this bridge where they gradually become comfortable with the healthcare system, and then they might consider going into for in-person. So that's the digital bridge or switch there between the virtual and in-person consultations. Continuity of care, again, you can have somebody being able to deliver care at one facility and then travel to another community and able to continue from there without necessarily having to carry any information. We already are seeing that with our electronic health record system, where we are able to see somebody's notes from their previous consultation at another facility. And the use of different forms of digital innovations or digital technologies, we are able to send reminders to patients and our clients on the appropriate time to visit and the appropriate time to come and see or come for refill or come for review of their medications. And so that allows for that continuity of care. And there's also the personalized bit of the care where we are able to actually use somebody's specific data to actually deliver care that is bespoke to them. And so there's tons of research, as I touched on the machine learning bit, where we are using machine learning models to actually determine. So take one of the common conditions that we typically have challenges with medication is depression. And so a patient will come and will cycle through a bunch of antidepressants until we actually settle on a medication that works best for the person, symptom-wise, improving their symptoms and not causing them so much harm in terms of side effect. And that is one of the common conditions that machine learning has been used. We are able to determine which patient, based on their characteristics, would benefit from one type of antidepressant as against the other, so that we are not just having a one size fit all for everybody. So everybody comes to prescribe this first line, and then when they go for 2 or 6 weeks, then there's no improvement. They will go on to another line, and so you are able to actually use that to say, okay, even though guidelines says first line is this, based on this person's characteristics and what historical data has shown us, this person will benefit more from a second line medication or something else other than what guideline is saying. But again, this is also guided by data because the guidelines are based on evidence, and evidence evolve based on evolving data. And so machine learning basically learns on historic data and is able to learn very quickly than how guidelines are developed. So this table again summarizes the benefits that I've talked about. It is accessible 24/7. You can chat with your chatbot at any time at all, without having to book or leave your house in the middle of the night. If you are going through any crisis, there's a chatbot that you can speak to, a smart speaker that you can talk to. And there is also the step care model that I've just described, which is basically using digital innovation or digital mental health intervention as the very first phase of access to mental health care, and so the person becomes more comfortable with going on to the in-person care. Now, polydigital or personalization here, I'll talk more about that, but it is similar to polypharmacy that we know, where you have different applications of different digital intervention being prescribed to a patient or a client based on their different needs. And these different applications, uh, in work in synergy, so that when one detects an abnormality in one side of its intervention, is able to recommend another, and then it kicks in. So somebody is going through some form of a depressive episode, and obviously their sleep would some way somehow be affected, and so they have an application that is tracking sleep, and that would definitely will pick up some abnormality there, and it can trigger something in the mindfulness app which the person also has on their mobile application, which would initiate some form of psycho education in another application that does. And so you have multiple applications working in a synergistic manner to produce a holistic outcome. But the risk yet then is that obviously, just as we have polypharmacy, multiple medications interacting with side effects, there is also that risk here as well. So this is the polydigital that I just described, where you have multiple applications working in synergy to produce a holistic response. Even if one application working alone might produce just a marginal effect, multiple applications coming together have the tendency of increasing or having an aggregate gains in terms of the margins of improvement of the patient. Right. So what are some of the challenges when it comes to the use of digital health intervention or digital health tools in mental health? The obvious one here, especially with the patient side tools, is the misinformation. And so if you have a blog post or a website which is written and run by somebody who is not an expert, there is a risk that there will be information there that is not verified and could be misleading, sometimes even harmful to these patients. And there is also the applications which add develop and put on patients phones, like app stores and Google Play stores, and they can go on and claim the ability to make diagnosis of conditions. And so patient downloads this, make diagnosis, and go around, mentioning to people how he has his diagnosis, even though it hasn't actually been confirmed by an expert. So you have a screening tool, but does not present the result as though it's screening, but actually presented as though it is a diagnostic tool. And so those are some of the risks. It will cause anxiety, overdiagnosis, and people probably overusing health facilities of health resources because of these anxieties. There is also the clinician burnout. We would think that using technology would ease the work of the clinician or the provider, but there's also the real risk that having multiple technologies that you have to juggle between would also cause an overload. And so, just as those of us who are in the clinic, the front line, have seen with the introduction of electronic health record system, there have been instances where people have spent longer time even before they get to actually finalizing a consultation of a single patient. And this is just one platform. So you can imagine having to juggle between multiple platforms, multiple alerts coming from different screens, and all of that. And so there's that risk that it can cause an overload and burden the clinicians or the providers. There is digital divide. We mentioned that one of the advantages of using digital technology in mental health care is the fact that it's able to reach people in remote areas and it's able to reach people who are underserved. The same people who are underserved, the social determinants that affect these patients or these participants or these clients in these communities are the same that will make it impossible for them to access these same tools. So somebody is in a village where they don't have lights and there's some river there, and the only way they get to the city is through a bus that comes in there through a bridge every Thursday in the week. And you say you want to use a telepsychiatry platform to give them consultation. Now, if they don't have light, how are they going to get internet or even any smart device of any sort that will allow them to use internet to access that care? And so there is that real risk that or challenge that we can we can marginalize people even more by using technology. And so it has to be a conscious effort in the development of technology or in the deployment of digital technology or digital health interventions that we do not exacerbate that divide. And so that is the risk here that using digital technologies can pose. The ethical considerations are there. So we have issues of informed consent. There is who owns the data, where does it sit in, how am I sure that this data is very secured? What happened to my data when it falls in the wrong in the hands of the wrong person? How do we ensure that this data doesn't fall into the hands of the wrong person? There's also, there's the blurry boundaries, professional boundaries here. We mentioned one of the advantages of using digital intervention or digital health interventions in mental health care is the convenience. So you are seeing a client who is sitting in their house wearing a pajamas. Typically, we don't see our patients in pajamas. So we have standards when it comes to that professionalism. So that patient provider relationship is kind of blurred. So you have convenience there. Somebody is lying on their bed and they want to have a consultation. Obviously, these are things that we will likely see, especially seeing patient who is going through some mood disturbances, is depressed, they don't want to get out of bed. And we said, okay, we are using a telemedicine platform. It is convenient, so you can stay on your bed and then we can have the consultation. Now, that is blurring that professional boundary. Even though we are kind of trying to push for that convenience, it comes with that risk as well. And so these are real challenges that come with the same advantages that the technology is offering us. And so it's a double-edged sword where we have to balance between what we are able to use the technology to achieve and what the technology can easily cause in terms of damages if it is not used appropriately. The big one here is also the limited evidence base. Medicine is purely evidence, so everything we do, every prescription that we are making is guided by some level of evidence. It might not be the highest or the purest evidence we've had, but that is the only evidence we have, and so it is guided. We are guided by that. Digital health technologies, on the other hand, are not, majority of them are not evidence based. As I mentioned, you have developers and software developers who are sitting in their lab somewhere, in the basement somewhere, building a code. And then as soon as it's done, they push it, and Apple Play Store gladly takes it, and then it is on the App Store or Google Play Store. Once they check all the boxes, it is there. Nobody, App Store doesn't ask what's the evidence base for this app. Neither does Google Play Store ask the evidence base. They are only checking about their codes and requirement documents, whether you've met them. But we as clinicians, we are worried about evidence base. what this application is claiming that it's able to do? Is there evidence for it? So currently, that field is still an evolving field, and it's a field that even the research methodologies themselves that are being used in evaluating these applications are evolving. And so it is very hard for most applications to actually tell you effectiveness of the application or the clinical effectiveness of the application, and let alone talk about efficacy of those applications. And so as a clinician who is looking to prescribe or looking to use this application, it is our duty to find out how much study has gone into this. There are a few of them that do have robust studies, and some of the purest evidence that we have in science, randomized controlled trials. Some of these studies have done them, just as you have, gone on to do meta-analysis and have been able to provide some evidence, and these are guided. That's why I mentioned those two repositories, especially with OCHA. They have some of these applications that have this evidence that guides the clinical claims of them. And so that's one of the key challenges that we have. And as providers who are looking to use or leverage these technologies, have to be very conscious and take active steps in actually asking the right question, just as we'll sit in a drug presentation in our morning meetings and query the pharmaceutical company who is presenting evidence and data. It is the same way we need to create these applications that are being used, and we should treat them just as we would treat any pill that we are prescribing for our patients. So with all these things, having said, the various applications, as you can see, I haven't talked about any particular digital health tool. I haven't gone into telepsychiatry, or I haven't gone into teleconsultation or telepsychology or e-counseling, because that's not kind of the topic of the discussion. I've kind of given an overview of everything, and hopefully this becomes the first talk of many that we'll have to educate ourselves on some of the tools that are available for us. And so telepsychiatry alone is a whole conversation on its own. And so each of these are bigger topics that we can take in and dive in subsequent conversations. So with all that I've said, we can see that there is already a lot that is already being used in terms of using digital interventions in the delivery of mental health care. But there's even more that is coming, and a lot of that we have already begun to see. And one of the key one is the buzzword AI, artificial intelligence, that everyone is hearing about. And so what does that look like in terms of using such tools or developing tools in that space look like? We've already mentioned chatbots already. And so these are chatbots. Again, we have chatbots that are generally out there. ChatGPT is not for a mental health. It's not a mental health tool. But people will go there and ask about their mental health condition. I have this, what is wrong with me? ChatGPT has been trained on a large corpora of internet information. And so it can spew out a lot of information that to some extent, or in most cases, are correct, but there are instances that it will give you wrong information. And so chatbots here, we are talking about clinically developed and validated chatbots. So and a research institution, or a psychiatric research institution or a psychological research institution takes up the mandate to develop a chatbot from ground up that is grounded on clinical evidence for mental health care. And that is what I'm talking about here, not the general chatbots that we have. So you can have these chatbots that are being used for just general conversations, engaging with patients, psychoeducations, CBT support as well. Then you can go on to talk about the traditional machine learning models that are used in predictions of suicide rates. So you have a model that goes on and actually scout the internet or scout somebody's social media handles to see what they are posting on social media. So you can have a natural language a processing model that is out there actually being able to process somebody's input. And there are instances, I mean, there's a lot of research that has been published on the use of these tools in predicting suicide. Again, most of these rely on identifying keywords where a person says something about they wanting to end their life, explicitly stating that they want to end their life in their social media posts and things like that. But majority of the cases, we don't have that happening. But we are able to actually predict with some level of certainty that this person has a very high risk based on their their interaction on social media and the posts that they've made on social media, and even the posts that they are engaging with and the comments they are making on those posts. So these are some of the things that are already happening, and there are studies that have already been published on the findings of these as well. I mentioned wearables that are used in mental health monitoring. These are things that we even can use, and we can even start to see how we can use them, because people are already using wearables. We have a lot of people who have Apple Watches now, or Samsung Watch, or some smart watch that they are already using. These wearables already track baseline vitals and physiological data, your baseline activity. So you can even check. So every day you're sitting, it tells you what the level of activity that you've taken, your heart rate, and then it tells you your sleep pattern. Apple was able to measure these things. We know for a fact that somebody who is going through some form of depression might have some sleep disturbance. Even their level of activity will reduce. We know there's anhedonia as one of the features there. So we can actually see. So you can actually, in your own clinic, somebody's wearing a watch. You can actually discuss this with the patient and have that conversation, that how do we actually access this data that this person is having, and be able to actually analyze. You'll be able to tell when the person is beginning to relapse. So somebody who has bipolar can be manic at any time, or depressed at another time. And you can see the levels of activities when they are beginning to spike. And so you know that this person probably, relapsing into, or is going into some manic episode. These are things that wearables are already doing, and we are able to tap into that. But it's just that it hasn't been consolidated into tools that are readily available for all of us. It has to be a conscious effort that institutions have to take, to say that we want to harness this data that is already out there in making our care, or in delivering our care. So these are some of the things that that will be available and are already available, but being developed and made more more accessible. But generally, these are things that you'll find in research institutions. I've talked about big data and population mental health. This is recording vast amounts of data. So when we say big data, we are looking at data that is being produced in large volumes at high velocity, and comes in different variety of formats. So these are some of the characteristics of big data. It's called the 5Vs, and that is what we are seeing with internet. And with the internet, we have a lot of, every click that you are doing, every page you are scrolling through is a data point. And so you have large quantities of data just streaming every second that we have. And all of this can be used in order to actually predict what is happening on the ground. What are people doing? During the COVID period, you could see the level of activities on the internet and what people were talking about. You can actually read or do social listening, as is described, basically reading into what people are saying in the general population level, and being able to use that to predict some spikes of some form of a mental disorder or mental distress, because we know there is an anticipated stress associated with a particular thing that is happening in a particular community. So these are some things that can be used or being developed, and can be developed, and that's how the future of care is going to look like. So my recommendations, or one of the key recommendations that I would make, which is kind of wrapping up this presentation, is what is described as a Tequila framework, which is a framework that is used if as an organization, or as a healthcare institution, as a provider, or at people who are at policy level that are looking to adopt any form of digital health intervention in their care delivery, even outside of mental health, just adopting mental health, a digital health intervention. These are some key areas that we should be looking out and making sure that they actually meet. We actually are hitting on these targets, and we are conscious about them. So the first one here is trust. And so that's what Tequila is. So T is trust, E is evidence, and then there's quality, usability, interest, liability, and then accreditation. So trust here is that you need to be sure that whatever you are doing, that the people who are going to be using it can trust the system that you are building. And that comes with all these models that I've talked about, and all these technologies that I've mentioned. There are quite a number of them that are very sophisticated, that it even defeats our own understanding. We are unable to tell what exactly, how the model came out with the conclusion that it does. ChatGPT now, we can't really tell how it comes out with any evidence. And these are described as a black box phenomenon in AI, where it is very sophisticated, that the output, how it arrives at a conclusion is very hard at explaining. And so now there is a push for developing of explainable AI, so models that are able to explain even how they arrive at their conclusion, or interpretable models that we are able to see their results and say, okay, as a human being, I know how this arrived or how this came to that conclusion. So we have models like that. So statistical or machine learning models, we know by formula that I know y equals mx plus c, simple linear regression equation, and I know the value of y given the value of x if I know m and c. And so this is a simple equation. There's no black box here. Logistic regression, you can deduce it. These are simple models. Decision tree models are easy to also understand. You know, if this is yes, it goes here. If it is no, it goes there. Everybody knows, you can follow the decision down. But with these sophisticated large language models that are being used, especially in the natural language processing that are used in developing chatbot, it is very hard to explain. And that makes it very hard to trust, because I don't know how you are coming to that conclusion. And so whatever technology we are anticipating to use or adopt, we should ensure that it is something that is trustworthy and that the end user can trust it. And that's where explainable AI and interpretable models come in. The evidence for what we are doing should also be robust. We should investigate, we should actually ground all our assumptions and applications on clinical research. And so we shouldn't just take it, the fact that it does what what it's supposed to do just because we tested it with two of our friends, it means it is able to do it at on the ground. That is not adequate. We should be able to investigate and actually invest in clinical research of the efficacy and effectiveness of these applications before we deploy them. Again, that is how evidence is, and that's how medicine has been. And so it was obvious from the survey that a lot of people did mention that as one of the issues, that they would use or they may use depending on the evidence. And that was one of the answers that majority of people selected for that particular question. The quality of the application itself that you are adopting or you are developing, it is something that needs to be checked continuously. And just like we have different stages of drug trials, stage 1 all the way through to stage 4, that stage 4 is very important. You can have it deployed, working and everything, FDA approved, and it's out in the wild. It can drift. There are drift of models. So you have model drifts or data drift, and the performance of that model deteriorates over time. So you need to have oversight of that. Whatever technology you have deployed, you need to have an oversight. And that's why quality and regulatory oversight is very important. And it needs to be the need for continuous evaluation. So that's where quality comes in. It should be usable. It should be something that's intuitive and adaptable to diverse population. And it shouldn't just be based on people who are literate and people who have gone to university and know how to use computer. It should be used, or it should be adaptable to diverse population, irrespective of their digital literacy level or socioeconomic backgrounds, especially if that tool is going to be used by them. So you can't be building a tool and be testing among your colleagues in university hospital, and then one that this tool eventually will trickle down to the chips compound where somebody doesn't have a computer there and probably doesn't know how to use some of the features of the application. So it needs to be adaptable to different user group, irrespective of their digital literacy. There should also be an interest. You don't just develop something or adapt something and put it on everybody. It needs to be a survey. There should be an intervention that primarily serve the interests of the end user. So whoever is going to be using this, is it the patient, is it the provider, or both, they need to be involved. These are key stakeholders who should be involved in the entire development and deployment. So there should always be some baseline understanding or survey, and not that one day there's nothing and then the following day there's everything, and then everybody's wondering, where did we get here? Yesterday we're using paper, today there's computer everywhere, and there's even no direction on how to use what and when to use what. And so there should always be some baseline interest, and should be a gradual exposure as you introduce these technologies. There should be, questions and discussions around liability. So if you adopt a technology, who is liable to this? If we go and adopt a digital platform that is used for teleconsultation or e-counseling, and then data gets leaked, who is in charge? Who is going to be responsible for that? Is it me, the provider, because they hacked my email and got to the software? Am I the one liable, or is because the software was not robust enough. That's how they got the data. Therefore, the software company is liable. These are questions and conversations that you need to have even before you adopt any technology. Because when it happens and you are now discussing it after the fact, then it becomes very difficult to resolve. And these are things, and these are most of the reasons why providers might be also resistant to actually adopting this technology, especially when we don't know where we stand and when it comes to these liabilities. And so these are things that, again, it goes back to regulatory aspect as well. And the last one here, which talks about accreditation, and that's where we are having these conversations, being able to educate people and enlighten. It doesn't mean that you have to go and do a whole master's program or go and do a PhD or an entire program. That's why we have CPD. These are continuous professional development courses, and there are works that are being done in place to ensure that we actually have an established curriculum that can be used to teach the different cadre of providers that we have in the mental health space, eventually such that we all will be on the same page when it comes to the use of technology in digital health, in mental health. So that is it, and these are kind of my key takeaways here. It is that digital innovation can transform, and it is already transforming mental health care. It has the ability to improve access, efficiency. It is quite efficient in doing that, and it is also scalable. But the rates that we have described are things that have to be actively, sought and actively managed. If you don't look for them and you are not consciously addressing them, they would come up and look as though they are impromptu, but they are not. They are inherently part of the advantages that the technology itself comes with. And we as clinicians have to be able to adapt to these changes as they are happening, which is where the accreditation, which I mentioned as one of the pillars of the Tequila framework, becomes relevant. So that is it for the presentation, and these are my references. Just before we get to the Q&A, I want to mention that these areas, these references that I have highlighted here are key references that I think if you're interested in learning more, you can definitely read on them. We have the telepsychiatric guidelines and policies by ACAP. So that's American Academy of Child and Adolescent Psychiatry. So if you go there, acap.org, they have a repository of tools and resources for just telepsychiatry alone, and they have a guide on it. And there's a toolkit as well, which is the second one here, reference number 4. If you go there, they have videos. They will walk you through on everything you want to know about telepsychiatry. They have their guideline and their toolkit. So if you're looking to develop or adopt some form of a digital health intervention or telepsychiatry platform, that could be a good reference to use. We also have the American Psychological Association guideline for patients and for the practice of telepsychology. And so they have a guideline there as well that also lists everything that you kind of need to know when you're adopting or deploying telepsychology or mental health platform or planning to use it. There's also the World Psychiatry Association telepsychiatry global guideline, which came somewhere around the COVID pandemic, when there was a boom in the use of telepsychiatry platform. And so that's a very good resource to use there as well. And then there's a digital health formulary that I've already talked about, OCHA, and then mine, which you can easily get through these URLs. Yes, so thank you very much. And then we will go on to the Q&A session. But before then, we'll go back to the survey briefly so that we'll see where we are currently on our understanding of the topic.
All right, Dr. Guzi, that was quite informative, I must say. Fully loaded, very, very loaded with all the information that you have provided us. Okay, there are no comments in at the moment, but can we do the post presentation analysis questionnaire?
Yes. So
Please,
I am
let's go
sharing
ahead.
that now. Yes, so that is it as showing here now. Just as with this, for the second one, you can, for the first one, you can scan the QR code, or you can just type menti.com and enter the number that's there. 12943196, and then give your response to the question there. Okay, I'm seeing some changes in the response that we got before. All right, we have 19 people respond, 15 people responding so far. Yeah, the responses seems to be different from what we had before. Right. Let's go on to the next question. Would you feel comfortable recommending or prescribing a digital mental health tool to a patient? Okay, we have over 20 people responding. And again, we are seeing that evidence-based here is playing an important role once again, that a lot of people are saying that they may use it depending on the evidence and the regulation around it, or they may prescribe it or recommend based on the evidence or regulation around it. All right. So what do you think is the biggest challenge in implementing digital mental health solutions in Ghana? Okay, I'm seeing a spike in low digital literacy here, which is, well, and the other responses are a little different from what we saw before, but definitely so low digital literacy as the biggest challenge. Okay. All right. So thank you very much, everyone, for participating. But before I wrap up this survey, I just wanted to quickly mention that all these digital interventions that we have here, all these tools that have been mentioned here are all forms of digital health interventions. So SMS notification reminders is an example of an mHealth or a mobile health application. We have assisted clinical tools. Also an example, AI application, we've already talked about that. I mentioned the repository there. Then we have electronic health record system. So all these are examples of digital health interventions. All right, thank you very much. And then we will take the questions now.
All right, thank you very much, Dr. Kuzi. Like I did say earlier on, that's quite informative. I mean, if you ask me, considering the opportunities that we have few opportunity to utilize this digital mental health, the tools that are available for us to use. The challenges are there, but like you did say, we will need to find ways of addressing them and making them more useful from our point of view. So thank you very much for that. At this point, we'll do the question and answer. The question and answer, please, if you have a question, you can write them in the chat box, or you can raise your hand. I identify you, you unmute yourself, then you make your submission. We are talking mental health, so please be kind enough in your choice of words, be sensitive enough. I see the first question in our chat box, which is coming from Anna Puklo Jade. Not sure if I understood you well. Are you proposing spying on people's social media in order to prevent possible suicide? At this point, Dr. Eugene Dode will also support us during the question and answer, so I would refer some of the question to him. So, yes, but Dr. Atkins.
Yes, right. So that's a very good question from Anna, and that goes back to one of the challenges that I mentioned as privacy and ethical concerns regarding that. But the comment I made was about tools that patients themselves have voluntarily downloaded and given consent. These are tools that you have to give consent to in order to allow you to do that, because of course at population level, governments are able to actually do these to some extent, where they are able to have some form of social listening on what is happening on the ground to some extent. But this one that we are discussing at the individual level is something that you have to give that permission for this application to be able to do that, and not that somebody is spying on you without your consent. But again, there's always that challenge between being able to personalize care and also encroaching on somebody's privacy. And that's where, informed consent and then the confidentiality issues come in, and has to be rigorously and, talked about at large even before you download and use this application. That's where, the American Psychiatry Association talks about the 5 models, where one of those or the place of accessing the application has to do with the data and the privacy of that data and the security around that. So you need to categorically give a consent to allow this application to invade that level of privacy, being able to listen to your social media and see what you are posting and what you are doing and all of those things. So that's not something that somebody should be able and can do without your permission to be able to do. That is the ethical way of going about that, and not spying on the person. Yeah.
All right. Thank you. Thank you, Dr. Kuzi. Comments by Doji Kuju. This is very informative,
like if I may add.
Okay, please go ahead.
So, yeah. I even before my appointment as chief executive, I mean, I am on the platform where we have professionals, persons with lived experience and their family or their support. And we've been on this platform for like over a decade. So 2 of them, one actually for bipolar and young people, the other for all mental health conditions. And both of them, you could look at somebody's posts in that group. And for one of them, which I have even published on it, I was able to use that chart to prevent a homicide. So this is somebody who was ill, stopped taking her medications, and then posted that her boss was evil and deserves to die. So I called her up and I realized that she was hallucinating, hearing voices telling her that she should kill her boss. And she had a means and opportunity because they ate together that day. And her plan was the friend that she would put poison in her food because she's evil. To cut a long story short, I managed to get the patient's boss to alert her, because as a mental health professional, you have a duty to warn a third party if your patient intends harming that person. So I had a duty to warn. So I warned the supervisor and encouraged her to lodge a complaint with the police. But more importantly, we're able to get the supervisor and the manager to get the patient to seek healthcare in Korle Bu. So, I mean, this is a paper I have with Dr. Delali Fiagbe about how we have been able to use WhatsApp or a social media platform to prevent a homicide. And that has been published in Nigerian Medical Journal. There's another publication also where we argued about using WhatsApp platform to keep almost every member on the platform who had a mental illness, I mean, be on their medication and not have a recurrence of symptoms that require them being admitted into the hospital. So it's not necessarily spying on them, but if you happen to know this person, if you happen to see their posts, you can actually tell whether they may be suicidal or not, and you can prevent it. Dr. Jade is my first teacher in mental health. Her hand is up. I think I have to keep quiet and listen to her. Dr. Jade, please.
Thank you very much. Yes, I am very much for being able to realize the person is relapsing when we are together at the same platform and we see the posts. That's what you now described, Dr. Dodoi. But
Yes.
However, when we are talking about, and that's to the presentation, when I was listening to the presentation, I really heard that we should be able to look through the social media and be able to prevent special, let's say, areas or special groups which they may be posting and all that. Who is going to do that screening? We are living in the age where we are all, we should all be worried about how much we put ourselves out there. And it is always double-edged, right? On one side, you may really figure out that somebody is homicidal or somebody is suicidal and we can help. But we should, as our presenter who did a very good job, as you mentioned, it has limitations, right? What you, Dr. Dodoi, described was special situation. You were already on that platform with other people, but we should make sure that there is limitation to it. Otherwise, we may start asking for more access or more vigilance or more really spying. So that's my caution. That's why I was a little bit worried. But thank you very much. The presentation was great, and your case was also very interesting. Thank you.
Thank you very much, Dr. Jade, still being around and supporting us. We are very grateful. We appreciate, I mean, your contribution as always. Thank you. Thank you. Yeah. Dr. Kuzi, I think there are other questions.
Yes, there's a question in the chat box, and this is for you, Dr. Dodoi. Where do we start from as mental health workers, taking into consideration our network system and policy guidelines? Practitioners are really handicapped in the field of practice.
Yeah, thank you very much. And I love this question, and I think it's Kujo Doji. Thank you for asking. So going forward, what the Mental Health Authority is seeking to do is to link all the districts or the regions that do not have any psychiatrists to a group of psychiatrists in training, the people we call residents. So those ones who do not have any person in their region or in their district to provide mental health care, they will be given access to some doctors who they can reach on phone when they have the challenges. I mean, as we develop this further, we want to get to a level where the mental health nurses or the community mental health officers will be able to do a video call with these residents. So they will see the patient and then help with a diagnosis and then with treatments. For now, it's going to be only a phone call, okay? And we are looking at how health insurance will also pay for the services and all that. So that is being looked into. But the whole idea is that we want the grassroots, CHIPS compound, everybody to have access to at least primary mental health care. Okay, so the prevention of mental illnesses, the prevention of complications, and the mental health promotion should be done at all levels. And that is what we are bringing the doctors and the psychologists into the fray, address that treatment gap challenge. Thank you very much, Doji, for asking.
Thank you for your response. Another question from Sabina. Dr. Kuzi, this is for you. Thank you, Doctor. On one of your slides, you said one of the tools could be used to offer exposure therapy. How effective is that, especially when the session is not in person, where the counselor or therapist is not present with the client?
Okay.
I think the person wants a little bit explanation of what exposure therapy is and what their
Yes.
virtual relationship would be. Yes.
Yes. So thank you very much for that question. Just to add on to what CE mentioned or commented on the last question, which had to do with also the network system. Going down even to the practicality of implementing these interventions, we would, again, one of the frameworks I've talked about is actually being able to ensure that these tools are accessible and not causing, or widening the access gap, which I've described here as a digital divide. And so we will be looking at tools that can be accessed even at low internet, places where you have low internet connectivity. So even the teleconsultations, it is not all teleconsultations that are done synchronously, just like we are having this Zoom call, which is a synchronous meetings. We can have teleconsultations that are asynchronous. And so you don't have to necessarily talk to the person in real time. You can have that conversation sent over to be reviewed and sent over to you, just so that because of the limitations of internet connectivity or because of logistic challenges, you are so able to benefit from these services. And so these are the frameworks that we've talked about here are things that we will definitely be using ourselves, and it's not just only for for speech and presentation. It's something that we are definitely applying to these interventions that CE has talked about. And to the question on exposure therapy, so I mentioned that one of the technology, which is virtual reality, that is used in exposure therapy for treating various specific phobias, and that the question of how effective are they? Again, that goes to one of my points of evidence-based. These are things that are evolving. So virtual reality is an emerging field that is becoming popular now, and people are leveraging them to try out these interventions. And so for research to be done in terms of their effectiveness, but there is some studies that have shown comparable. Of course, there's usually a variable data on these evolving fields, but there have been research that have shown research that or the challenge here is that just as you have those emotional therapy in person, it is the same thing that somebody there and this person is doing it on their window, if there's that risk there as well. But the evidence supporting these emerging technologies are so very limited and are so areas that are being researched in. So yes, that's what I can say about that.
All right. Thank you for your response. Deborah Mensah, very insightful and informative. Thank you, Deborah. Jones Kwesi Agbo, please, do the health regulatory bodies, example, MHA, GPC, in our country take interest in checking the credibility of some of these digital platforms, since you mentioned as one of the limitations as misinformation and over-diagnosing? I'll refer that to Dr. Nodoi.
The short
Dr.
answer
Nodoi,
is yes.
thank you very
In
much.
fact, even this week, we have had a letter from NITA. NITA is, do I remember their full? But they are the regulatory body for things which are, deals with IT in Ghana. So they regulate and check cybersecurity and all that. We wrote to them that we have a tool we are using which has a video conferencing and all that at Accra site. So can we go ahead and use them? They wrote back to us that we've not given much detailed information for them to even begin to even look at it or consider it at all. So we should provide information, then they would know whether they should permit it or not. So we can't just use any platform or any tool at all. There must be regulations. When there are even no local regulations, there are, international regulations, like the one from the US called HIPAA, that protects patients' information. So once you use them, you are obliged to respect international agreed, guidelines. You can't just use any tool, any guideline anyhow. All right, so yes, the regulatory agencies can check or will check, but I think the level at which technology and AI is advancing, I don't see any regulatory body being able to catch up with the speed of advancement because it's going very fast. Before you know it, there's another way of doing something else. But for Ghana, we are yet to start with a telepsych, and it's going to be with health insurance as well. Yeah. Dr. Atta.
Yeah. Yes, thank you very much for your response. In actual fact, it looks like you preempted my personal question, which refers to how these tools are being developed. Now, considering that they are rapidly evolving on the landscape, if I as an individual or as a clinician, what key markers would I be using in my choice of a tool? For example, a health promotion tool, personal health promotion tool. What are the things do I need to look out for so that I can confidently and easily use these things without being worried, considering that every other day there are new tools coming up? Dr. Kuzi.
All right, thank you very much, Dr. Atta, for that question. Let me quickly chip in on the last question regarding the regulation as well. And so if you look at the tools that I talked about, they are the clinical tools, which are mostly regulated. And then you have the patient end tools that are mostly out in the wild that are not regulated. And so there's a gray area even in the regulatory landscape where some tools, regulators themselves takes a hand-free approach to them just by the labeling of those tools. So somebody develops an app and says a wellness app. Wellness app are by nature not regulated. So FDA does not regulate wellness app. And that's a lot of the apps that you go and you see the category of them. But then when you go into reading what they actually claim that they do, they will tell you that they are managing depression or they are managing schizophrenia or bipolar or they are doing that and that and that. But they have actually comfortably classified themselves as wellness app and therefore has escaped that regulatory, or they have kind of used that regulatory loophole to escape regulation. And so a lot of these apps, and that's why I kind of mentioned these app repositories that we as providers can use, because these apps making themselves to these repositories have gone through some external third-party verifications. But for the ones that are deployed at healthcare systems, those are heavily regulated, as CE has already talked about. Regarding what key markers we should use as providers when we are looking to adopt these tools, again, one of it is evidence. And I said that's actually the key thing that you should use. What is the evidence for this tool? We are evidence-based, we practice evidence-based medicine. And so just like you evaluate any pharmaceutical, that is the same way you should scrutinize and evaluate a digital health intervention. So you can use the PICA framework, which is looking at what is the population on which this tool was tested on. What is the intervention and what is the comparator? Which people did they compare it to? Again, that's the thing about these digital interventions and even the studies that are done in evaluating them. There's limited evidence for even the cohorts or the control group that are used in comparing to these. And so you as a clinician who is looking to adopt this, you have to see, like, this tool that they are claiming is able to do this. What evidence do they have? The population that this tool was tested on, is it similar to mine? So if you just use even the baseline PICA framework, which is what we use in evidence-based medicine, to compare anything that we want to adopt for our use, you realize that a lot of the tools will fall out of that. And so now you now have a very few list of tools that are still hanging in there and have some limited evidence that you can use as a provider who is sticking your head out to recommend that tool. And so that's where these repositories, to some extent, have done that work for us, that we know that if a tool has made it to OCHA, there is some independent body who has actually done that process for us. But even us, who is still the one recommending and prescribing, we still have to go in deeper to see what the evidence base that is supporting these tools before we go on to prescribe them or to recommend them to our patients. So I would say the key marker is definitely evidence-based. And if you want to do the assessment on your own, you can definitely look at the most five pillars of their association in assessing these models. Looking at accessibility, data privacy, the cloud that the data claims to, or the app claims to do, and all those 5 frameworks. Again, if you want to actually do that all by yourself, you could do that. But these apps that make it to these repositories have already kind of gone through that, and you can see how each of them score on each of those pillars. Yeah, thank you.
Thank you very much. Would you be kind enough to share your references again, so those of us who want to pick that repository, we can have it and utilize it?
Right.
I don't. Yes, thank you very much. Don't see any hand again.
All right. So this is for American, so ACAP, which is American Academy of Child and Adolescent Psychiatry. So if you go there, acap.org/telepsychiatry toolkit, within that same site, you will see the videos that they have that teach you or walk you through some of the areas that we've already talked about. So that is that. There is the mind map, which the mind apps, which I've already talked about. OCHA, if you type OCHA on your browser, so ochahelp.com, you'll be able to also get that as well. And so that is this one there. So ocha.com should give you the list of the apps. Unfortunately, some of those apps are actually paid for. And so, as I mentioned, OCHA, for instance, is something that has very high standards and is being used by NHS, made available to their clinicians through their e-health system. Mind Maps, which has purely mental health applications, is freely accessible, but as to whether the app you get them for free depends on the app level access. And so you can filter by free apps and you can filter by those that are paid as well, and look through to see how they perform on each of the 5 pillars stated by the American Psychiatric Association app evaluation pillars. So these are some of the things that you can definitely look into for more information. Yeah.
All right. Thank you very much. On that note, there is no hand up and there's no question. We'll bring the session to a close. It's exactly 1 minute past 4 when we said we're going to end the session. So thank you very much, Dr. Akins Kuzi, for that informative and insightful presentation. It's been very worth it. I mean, the opportunities for us as a country, as a sector, is very clear to utilize this digital mental health. The challenges and the risk, I think that we will have to find ways of dealing with it, because the benefits far outweigh these challenges, and we must also utilize them. So thank you very much for that wonderful presentation. And to you, Dr. Eugene Dodoe, for all the support in getting this program to come off. Thank you very much. And to our wonderful participants, we also thank you very much. We thank you very much for always attending and listening. Without you, these programs wouldn't know how beneficial and how impactful they are. So we always attend and we're able to take data from these things, and we always try to improve on what we are doing. So thank you as well for coming. It's been a wonderful afternoon of knowledge, information. It's very little entertainment, but we are here for knowledge and information. So thank you very much all for coming.
Thank you.
Thank you all very much for coming.
Thank you, everybody.
The program has ended. Thank you very much. We'll see you pretty soon. Have a wonderful weekend.
Enjoy your weekend too. Bye-bye.
Bye.